All right, we're going to get started with the second presentation. This is going to be Opportunistic Infections and HIV. So I left it vague because we're going to do clinical cases for this. So basically we're going to review pathogenesis, clinical manifestations, diagnosis of select OIs, and we're going to discuss challenges in diagnosis and some treatment options for these OIs in HIV-positive patients. All right, so we're just going to start with the first clinical case. So we have a 28-year-old male, comes to the ED with a 3-week history of progressive productive cough, worsening dyspnea and fever. This morning he was barely able to walk 2 steps without being extremely short of breath. His last CD4 was 150 and he's non-compliant with ART. And again, when questioned further, he's like, well, it's not really a productive cough. It's sort of dry sometimes, but basically 3 weeks of cough and fever and shortness of breath. And then we do a chest x-ray, and this is courtesy of Google, not the real patient. And you have an ABG where your pH was 7.4 and your PO2 was 65. They checked a 1,3 beta-D glucan that was 100, and their O2 sat was 85% on room air at rest. So, what is the best next step? Do you guys think you should treat empirically for a bacterial pneumonia with a zithroencephaltriaxone? Do you treat with trimethsulfa and obtain no further workup? Do you treat with trimethsulfa and steroids while you're awaiting a BAL? Or do you hold off on anything? You don't do anything until they do a BAL. What do you guys think? So some of those are pretty obvious. That's not the right one. But who votes for A? Nobody. Who votes for B? Nobody. Oh my goodness, you guys have been rotating an ID. Who votes for C? Okay, good. So you guys know that this is what? Pneumocystis, right? Okay, so, my bad. So yes, that was the correct answer, and let's walk you through this. So this is a Pneumocystis eurovetzi, and most recently identified as a fungus. Thought it was a protozoan for a long time, but finally with RNA sequencing, this is a fungus. Usually folks have to have a CD4 that's less than 200 or less than 14%. And the key here is that it's a subacute presentation. So if you have a patient that said, I started getting sick 2 days ago, then it's less likely that this is pneumocystis. Again, that being said, we've had several patients that felt poorly for weeks and then all of a sudden 2 days ago felt sicker. So then that's confusing because they had pneumocystis but they also had strep pneumonia. So, these patients, the key is that many things can happen at the same time. Though we like to tie everything to one diagnosis, you have to remember that these folks who are immunocompromised like that, they can have several things going on at the same time. So in terms of how do you diagnose? So okay, ideally, yes, you want the BAL, you want to have the silver stain, and you want to see the pneumocystis or get a PCR. That's the ideal. However, it doesn't always happen that way and that quickly. You don't usually get the BAL like right away the next 5 minutes. So there are certain clinical criteria that you can use to make a presumptive diagnosis, and that can steer you towards empirically treating this patient for pneumocystis while you wait for additional diagnostic tests. And you might say, well, why do you need additional diagnostic tests if they're going to respond clinically? The key being that these people can have 1, 2, or 3 things going on at the same time that require different treatments. So that's why you still want the diagnostics, but you can start empiric therapy. So what are those clinical criteria for pneumocystis? So one, obviously, if you have a history of HIV or other immune compromising condition, and your CD4 is less than 200 or less than 14% because you're at risk, you should have compatible symptoms. So subacute presentation with mainly fever and cough, right, and shortness of breath that's progressive. Chest x-ray with classic appearance. So basically you're looking for interstitial/alveolar infiltrates, okay? That being said, pneumocystis can present as a lobar pneumonia as well, but the classic presentation is the bat wing appearance on the chest x-ray or patchy ground glass opacity on your CT. Okay, that works too. And the other thing that they use is the 1,3-beta-D-glucan. This is a component of the fungal cell wall, and if it's above 80, that's a good indication that this might be pneumocystis. It can cross-react with other fungi, but given the presentation and what's going on, this is what you would use. And a lot of times they talk about LDH. Yes, we did use LDH previously, but now it's kind of become a non-specific marker, so this kind of is a little more directed towards a fungal pathogen. So you can use these clinical diagnostic criteria to make a presumptive diagnosis and empirically treat your patient, okay? What else is key for pneumocystis? So this is one of the diseases, infectious diseases, where you have a lot of inflammation. So there's not a lot of infectious diseases that we say, oh, we're going to throw some steroids to help out, right? This is one of them. So this and TB meningitis would be the other one. And what other meningitis, guys, that you have to give steroids? Yes, somebody said strep pneumo. Yes, strep pneumo. Okay. So those are the few that I can say off the top of my head that you stick steroids on top of an infection. But pneumocystis is one. And this is indicated for severe or moderate disease. So you can do it clinically, or you can also look at these parameters. So PO2 less than 70 or AA gradient more than 35. That's suggestive of bad disease, so you can't, yes.
Is thrush still one of the...
Yes, I think you're thinking of criteria for prophylaxis, like primary, yes, and I will talk about that, but yes. And so the diagnosis we talked about, ideally BAL with a silver stain, or if you have PCR, but you can use your clinical criteria. And these are the treatments. I didn't stick a whole lot of doses in there because those are things we look up as we go. Just so you know, the preferred regimen is trimethylsulfa. And if they're sick enough to be in the hospital, you do it IV to start with, okay? There are some alternatives here in case you're allergic to the sulfa component. So you can use clindaprimaquine, just the TMP with dapsone. Atovaquone is only for milder disease because it's not as efficacious. And you can use pentamidine as well, IV. This is not very easily accessible either. And if you're going to do the steroid taper, it's for 21 days, as is duration of treatment for the primary infection, okay? And this is what you were talking about, where it says starting primary prophylaxis. Basically, you've never had disease and you want to prevent your patient from ever getting it. So the indication is CD4 less than 200 or less than 14%, or oral candidiasis. That's what you were talking about. And we usually use the trimethylsulfa, and you can do a double strength daily if you're also prophylaxing for tox, or you can do a single strength daily or a double strength 3 times a week. There's several permutations of that, but normally I just do a double strength daily. It's just easier. You stop it if you have a CD4 above 200 for 3 months on ART, and you restart it every time it drops below that 200 or 14%. And basically for stopping secondary prophylaxis, which means you had PCP and you finish your acute treatment for 21 days, you do put them on this prophylaxis until they get CD4 above 200 for 3 months, okay? So that is what the indication for prophylaxis is. So we're going to jump on to case number 2. So you have a 30-year-old male who's HIV positive. He is non-compliant with ART. You're going to see a common theme here in all of these OIs. They're non-compliant because when they're compliant, they don't get this, okay? So he's non-compliant, comes to clinic saying he has worsening headaches over the last several weeks and blurry vision. Today he has a stiff neck, but no neurologic deficits noted on exam. His CD4 is 95, viral load's 100,000, and also complains of a rash. And this is not my patient because this is from the New England Journal of Medicine, but we've had a similar case. So this is the rash they have. And so what's the next best step to establish diagnosis? We do a urine antigen test, a skin biopsy, or a lumbar puncture. So the first step of this question is figuring out what you think they have, right? Because that's going to guide you. So how many people vote for the urine antigen test? Nobody. Okay. Who votes for the skin biopsy? A couple people. Who votes for lumbar puncture? Okay, most people vote for lumbar puncture. Would you image this person first before you did the lumbar puncture, or would you go straight to the lumbar puncture? Who wants to image first? Okay. And who doesn't want to image? Nobody's going to answer that one. Okay. All right. So what do you guys think this is? What do you guys think he has? With the, basically it's subacute progressive headaches and now having some meningeal signs, right? Those are the big main things. And the skin rash. What do you guys think this is? Okay, crypto. Any other votes for anything else? No. Okay, so this is disseminated crypto, and it is lumbar puncture, but I would image first. I know sometimes we say, well, the literature says that if you don't have a neurologic deficit, you should be okay to do an LP, and in general that's okay, but in crypto you can have obstructing hydrocephalus sometimes, and so you want to make sure that that's not the case, and that's why you would image first. But this is a life cycle, so this is crypto neoformans. So basically this is in the environment, and here's your little bird pooping and in the trees, and then there's your spores. So you basically suck that in, you inhale that, and it can stay in the lungs, but after that it can disseminate, and one of its preferred sites is the CNS, okay? And so that's the cycle there. As far as clinical things to remember, it's an encapsulated yeast. You're at risk usually if your CD4 is below 100. And again, the big thing is a subacute meningitis. You can have the pneumonia too, and the skin lesions. And, you know, before we used to do the India ink, and that was like the nice, beautiful picture that you have. It's not done so much anymore. You can do any fungal stain. You can do a regular GMS stain or a calcifluor stain. You can do any of those. And of course, you can do your cryptococcal antigen both in the serum and in the CSF. However, that does not help you follow disease, okay? And it's unclear of as far as how long it takes to clear that antigen from the CSF. So you can do it as to try and, you know, say that it's there, but it doesn't help you follow disease, okay? And so we talked about this already. So we image to assess for obstructing hydrocephalus. You do your LP. Very important to measure the opening pressure. These guys are usually going to have an opening pressure of above 45. So your goal is to get that opening pressure to 20 or below 20. Okay, that is very important, and that is why in the past you would even when I was in training, you would do serial LPs in these patients. Again, that's not the most convenient test to be doing at the bedside every day, but a lot of us got certified on LPs on the one cryptococcal patient that was on the ward, because every day we would do this. You can opt, if your opening pressure is not decreasing appropriately, you can opt to have a lumbar drain. That's an option too, but this is what helps get symptoms under control, okay? And like I said, of course your CSF is going to be very important. Your findings are going to be consistent with a non-bacterial etiology, so not a huge white count there, mostly lymph, so you're going to see that. You could do your culture and your stain, your fungal culture and stain, okay? And we talked about the serum cryptoantigen already, and you can grow this in the fungal blood cultures as well. As far as treatment, once you've established the diagnosis, right, your induction therapy will be Ampho-B with flucytosine for at least 2 weeks. And we say 2 weeks if your repeat culture, so you're going to do 2 weeks, so maybe at day 10-ish, repeat your CSF. If that's sterile now, then you can stop at 2 weeks. If it's not, you keep going for 4 weeks or however long it takes to sterilize, okay? After you finish the 2 weeks or what have you, you go to consolidation where you can switch to fluconazole for 8 weeks. And then maintenance, you go to fluconazole lower dose for a whole year. So this is a very involved set of treatment, okay? These people are on therapy for a whole year at the very minimum. And remember, this compliance is key here too, to avoid relapse. You can stop the maintenance therapy if certain criteria are met. So if you're asymptomatic, your CD4 stays above 100 for at least 3 months after completing all that, 1 year, then you can go ahead and stop it. But every time it falls below 100, you should restart it because the risk of relapse is big, and people get very sick. This is a high morbidity, mortality disease if it's not treated, okay, and people are not on suppression therapy. All right, let's jump into the next one. You have a 41-year-old male. He's HIV positive, comes to the ED with new onset witnessed grand mal seizure. He has never traveled outside the U.S. His CD4 is 56, his viral is 250,000, and we recently started ART and OI prophylaxis about a week ago. The CT brain shows multiple ring-enhancing lesions. So what do you think's going on here? So is this toxo? Is this neurocysticercosis? Is this primary CNS lymphoma? Well, one thing you could probably eliminate is probably neurocystis, because I kind of made a point to say that he never traveled. Of course, you can still get this by other means, but let's pretend that that's so. Do you guys think this is toxo, or do you guys think this is primary CNS lymphoma? Who votes for A? Who votes for C? And who votes for that it could be either or? Okay, good. So it's very difficult to figure out which one it can be, okay? Now, if there's a single lesion, you know, it kind of steers you more towards going for the malignancy because it's a single lesion. If you have multiple lesions, you kind of veer more towards tox. But the truth is, you really don't know. And that's why we end up doing brain biopsies. But brain biopsy does carry a risk with it. So very often you'll see us do 2 weeks of empiric therapy. Of course, if their IgG is positive, okay, guys, because this is a reactivation disease. This is not a new thing. This is reactivation. So if their IgG is positive, we usually do an empiric course of 2 weeks, and then we check imaging again. And if it's better, then that kind of tells you probably what it is. If it's not better, you do need a brain biopsy, because you don't want to waste time doing 6-8 weeks of toxotherapy when they have a lymphoma, okay? So the truth is, it could probably be either or, and that's why that was the answer. But just to remember, toxo, you have your kitty here, right? Kitty's infected and is pooping. The rats and the birds are eating the poop. And then the kitty is also going to eat them, and then they're going to get encysted. So this goes on. But what happens is there's rogue one, right? So instead of this being eaten by these guys, these getting eaten by your pig and your sheep, and they also get in vegetables that people are growing in the soil and in the kitty litter box. People make a big deal about it, but it can also just be in the soil where you're growing your fruits and veggies. So the farmer's market, fresh fruit and veggies, well, you can have all that there. So when rogue one gets encysted into pork and you eat that, then you can get it. Of course, here blood transfusion. And if you just ingest the cysts from dirty fruits and veggies, or if you're inhaling when you're cleaning your kitty's litter box, if you're inhaling fresh stuff there, then you can get it. But this is the cycle, okay? As far as other things to remember, it's reactivation, low CD4, 50 or less. 11% of people are seropositive in the U.S., so subacute symptoms are also the hallmark of this. So you can have the fever, the headache, altered mental status, and then all of a sudden you start having neurodeficits and you start seizing. So that's a big one. Diagnosis, MRI helps you, ring-enhancing lesions. Clinical symptoms, of course, biopsy if you can, and positive toxo IgG. Treatment, again, 3 drugs: sulfadiazine, pyrimethamine, and leucovorin for 6 weeks or until MRI improves or resolves. Usually they do almost completely resolve by this point in time. Maintenance dose is it's the same 3 drugs but at lower doses. And basically prophylaxis, if your CD4 is below 100, you do the same drug you do for pneumocystis, so it's trimetsulfa, and you continue until you get their CD4 above 200, okay? And you can continue maintenance until you complete the acute treatment. They're better, asymptomatic, MRI is better, and their CD4 maintains above 200 for 6 months, okay? All right, jumping into case 4, there's 7, yes?
So for our HIV positive patients that really love their cats, should we tell them, like, can they get protection by like wearing?
Yeah. So so you know, I'm a big cat lover, but I don't tell anybody to get rid of their cats. But I do tell them the first thing is if you scoop your box daily, you're at less of a risk because it takes time for those cysts to mature. So if you clean your litter box daily, you probably won't get infected. And I say wash hands, use gloves, wear a little mask, don't take deep breaths when you're cleaning, or get someone else to clean, you know. Yeah, I don't tell them that it's absolutely necessary to get rid of their cat, but I will explain this is what can happen, blah, blah, blah. And of course, if they're already toxo IgG positive, doesn't matter. They already have it in them, so they can keep kitty, okay? Does that make sense? Okay. All right. Jumping into case 4, so I have a 50-year-old female this time. She's HIV positive and starting to have this progressive cognitive impairment, just not really making, you know, having difficulty understanding things, and now difficulty walking and new right lower extremity weakness of acute onset. CD4 is 180, viral load's 37,000, and again, the theme, poorly compliant with ART. So what do you guys think is going on? Is this HSV encephalitis? Is this cryptomeningitis? Or is this PML? Who votes for A? Nobody. Who votes for B? Well, we already talked about that, right? I should have made this harder. Okay, so who votes for C? Yay! Okay. All right. So this is what it is. Okay. So this is PML, and this is caused by the JC virus. Does anyone know why it's called JC? Because of first patient that was described was John Cunningham, so they called it JC virus. It was not Jesus Christ. It's John Cunningham. Okay. So basically, this infection is thought to occur initially in the tonsils. So that's initially where the virus likes to stay. Most of us have been exposed. Okay. And the latent site is kidneys and bone marrow, and again, reactivation disease, okay? And so most of us have been exposed, most of us have no big deal because our immune systems are intact and working well, and it does have a predilection for the brain, okay? And so this is a polyoma virus. It is a demyelinating disease. You're at risk when your CD4 is between 100 and 200, 40 to 70% seroprevalence in the U.S. Okay, and again, a chronic subacute presentation, and it can be associated with hematologic malignancies as well. And there have been a few case reports on folks who are using the TNF-alpha blockers or some of those immunomodulators. They seem to get this as well. So that's another population you might see this in. As far as diagnosis, clinical features are important. So it's a subacute onset of neurologic deficits. There's no fever. There's usually no optic nerve or spinal cord involvement. So those are some of the things that help you. Then you look at MRI features. It can be unifocal or multifocal lesions of the white matter, so demyelinating disease. The lesions are typically non-enhancing and they don't have a mass effect. And of course, you can do a CSF and look for JC virus PCR, quantitative. You can do that. Sometimes they do brain biopsies, not real often, but basically this is what would lead you to think of that diagnosis. As far as MRI findings, you can see these areas here, and there's no specific treatment targeting JC virus. They have looked at cidofovir and other antivirals, but there was no proven benefit of those. So basically our treatment is our antiretroviral therapy. It's reconstituting your immune system so that you don't have problems with this. Mortality, though, is about 30 to 50% within 3 months of diagnosis. So this is usually carries with it a poor prognosis. But there's no real treatment other than antiretroviral therapy. They also looked at, can we use antiretrovirals that get into the brain better, because maybe that will have some effect on it, and it hasn't really been proven to be the case. So your standard antiretroviral therapy without having to do things like efavirenz that has other side effects but gets into your brain. But it is a thought that was looked into. All right, we're going to move on. Clinical case 5. So now I have a 55-year-old female. She has skin lesions several weeks ago, but now she's having fevers, weight loss, and night sweats and malaise. She doesn't have any pulmonary symptoms, no recent travel, no exposure to TB. She does have some hepatosplenomegaly and pancytopenia, and the most recent CD4 was 125. So what's the most likely diagnosis? Is it malignancy? Is it strep pneumo invasive infection? Is it disseminated histo? Or is it extrapulmonary TB? Who votes for A? So basically protracted course, weight loss. I'm going to go back here. So weight loss, night sweats, malaise. Then hepatosplenomegaly and pancytopenia. That's the summary. So what do you guys think? Malignancy, strep pneumo, histo, or extrapulmonary TB? Who votes for A? Okay, could be possible, right? B, anybody? Probably not. This is very chronic-ish. Disseminated histo, anybody vote for that? Okay. And what about extrapulmonary TB? It could be, right? I kind of made sure I said no exposure, no blah, 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 no recent travel. Okay. So you guys are right. I mean, obviously I'm talking about HIV-related OIs. It could be malignancy. That could certainly fit all of that. But in this case, I'm talking about histo. Okay. So what about histo? Where does it come from? So now you have bats pooping, not birds. So you have bats pooping. Then you're sucking it in with your deep breaths. And again, it's a lung and then dissemination. Okay, so that's kind of how. And we're in Kentucky. And so we have this. Okay. So the key here is those systemic symptoms. Histo very much mimics TB. They're very similar. Actually, in the beginning, some people got used to get misdiagnosed with TB, but they had histo. In fact, more recently, I had a patient who had the miliary pattern. They empirically started him on all these TB therapy. Well, not here, somewhere else. They started him on empiric TB therapy, and I'm like, well, nothing is positive, like no cultures, no, even the quantiferon's negative. I'm like, okay, I'm going to do a histo, and this, of course, it came to clinic, right, to establish care. So I did a histo test, antigen test, and it was positive. So this guy actually had histo, so I could back off on all the TB meds and treat him for histo, and he got better. So CNS involvement can happen. And you can also get this picture where you're hypotensive, multi-organ failure, ARDS. You guys had a patient not too long ago in the unit that had this exact picture and had some skin lesions and just kept getting worse and was in septic shock. Pulmonary histo is another presentation, as well as skin lesions. Diagnosis, antigen detection test, very useful. You can do this in the urine and with a quantitation in the BAL or CSF. Serology, of course, is there to help you. Fungal cultures. Definitive diagnosis is really biopsy and histopath. Is basically where you're going to see this. And sometimes if there's enough burden of disease, you can get it from a fungal blood culture. You can see it, okay? But path is really important to get histo.
Is the beta glucan useful?
It can be positive. It can cross-react. So histo and blasto, you can have that positive, yes. So as far as treatment, again, you see the recurrent theme, right? Poor, like low CD4, poorly compliant, and then treatment goes on for a year, like for most of these guys, okay? So Ampho B for 2 weeks. If it's meningitis, 4 to 6 weeks. You then switch to ITRA, which has a ton of drug interactions, so we have to be very careful with that. And that goes on for 12 months. and then you go to suppressive therapy. And you can stop the suppressive therapy after they've completed at least a year of treatment, their fungal blood cultures are negative, their histoangine has gone to below 2, and their CD4 is at least 150, and they've been on ART for at least 6 months. So there's a lot of criteria to be able to eventually stop the suppressive therapy, but you can eventually get them off it. All right, next one, 42-year-old female returns to the 550 clinic to reestablish care for HIV. She's been off ART for 3 years, and her current CD4 is 22. And she says that, you know, I just can't see right. I can see very little out of my left eye. This was an actual patient. So then you do the smart thing. You send her to ophthalmology, right? Because I can't read a fundus to save my life. So I send her to ophtho, and then this is not my patient, but this is what they saw. And for those of us who can't really figure out what that is, that's the reading for that. So you have intraretinal hemorrhage, and then you have these patches of white surrounding, retinal whitening surrounding the hemorrhage, and then you have this perivascular like exudates. So what's the most likely diagnosis? Is this CMV retinitis, toxoretinitis, MAC retinitis, or HSV retinitis? I'm sure there's some things on there that don't really exist, but which ones who votes for A? Okay, and then who votes for B? Okay, and what about C? I'm sure if you look up a case report, there must be something like that. This is not a traditional presentation. And what about D? Usually we talk about HSV keratitis, right? So, okay. So yeah, this is CMV retinitis. And just for an idea, you guys already know this. Here's your virus, right? And then if you're immune suppressed, you get end organ disease that can affect mainly your eye, but it can also affect your brain. You can have encephalitis. Pneumonitis is extremely rare. So don't freak out on those patients where you do the BAL and you have pneumocystis and CMV and you're like, oh, which one do you treat? The pneumocystis. The CMV is probably just hanging around there. Pneumonitis is rare. And of course you can have colitis, esophagitis, right? Those are like big ones. And then, of course, congenital infection is there, and that can lead to problems. As far as the CMV, we do know it's a herpes virus. You're at risk when your CD4 is less than 50. Hers was 22. It usually starts out unilateral and then goes to bilateral, and it is the most common end organ manifestation. Now, if you have CMV retinitis, there were some studies looking at what is your chance of having encephalitis, right, because it's all close by. And some studies even cited a 75% correlation. So this is helpful in those patients who are like altered mental status and you know something's going on in the eye, then you have to be suspicious for the brain as well, and you have to do your appropriate studies and treat that encephalitis appropriately. And other manifestations we already talked about, colitis, esophagitis, encephalitis. You can have a polyradiculopathy described as CMV, and pneumonitis is rare. The ophtho exam is obviously key, and a good ophthalmologist can tell you by the clinical appearance that this is CMV retinitis. You can do a CMV serum PCR. It's not super helpful in terms that sometimes you can have colitis with a low PCR. Sometimes you can have a high PCR but no disease. So it's important to make an appropriate correlation. And for things like colitis and esophagitis, the biopsy is what's going to establish diagnosis. You're going to see the intranuclear inclusion bodies, okay? And how do you treat CMV retinitis? So there's two courses of action. If you have a non-sight threatening lesion, which your friendly ophthalmologist is going to tell you, right? In those cases, if your sight is not in immediate danger, you usually just do systemic therapy. And actually, we've moved to doing oral valganciclovir, okay? And you do that for induction 14 to 21 days, and then you do maintenance therapy for a minimum of 3 months. It really depends on your response to therapy, which your ophthalmologist is going to tell you about. If you have a sight sight-threatening lesion, then you are going to do the intravitreal injections. Well, not you, the ophthalmologist will. And that goes on in conjunction with the oral therapy, okay? And then you also do maintenance therapy. The key here, the shift has been, before we used to be restricted to be doing IV ganciclovir or maybe foscarnet, and those have a lot of side effects. They're hard drugs to tolerate, lots of toxicities. The oral is usually well tolerated. The only other instance where you wouldn't do the oral is somebody who couldn't tolerate PO. Then you do have to do IV, because you have to get some medication in there to try and preserve sight and halt progression of disease. This is the last one, okay? So this is a 30-year-old guy that was recently diagnosed with HIV, and he initially presented with Pneumocystis Pneumonia. He was successfully treated with trimetsulfa and steroid taper, and we started the ART, right? After being on ART for approximately 3 weeks, presents with cough, fever, shortness of air. Chest x-ray shows bilateral pulmonary infiltrates. He's very compliant with his therapy. His initial CD4 count was 50, and now it's actually going up. It's 150. So this is like the opposite of all the people we just talked about. So this is compliant. CD4 is going up, but he's getting sick, and it looks like the same thing he had before, right? So what's the most likely diagnosis? Is this recurrence of pneumocystis due to failure of ART? Is this immune reconstitution inflammatory syndrome, IRIS? Is this MAC now? Or is this a community-acquired pneumonia because everything is going right, but now he has these symptoms? Who votes for A? Nobody. Who votes for B? Okay. And who votes for C? Okay. Could be, right? Who votes for D? Could be, right? Okay, but my point here that I'm trying to make is exactly what I said before. This is the opposite of all the trends we've seen. So this is immune reconstitution inflammatory syndrome. So let's talk about this. So this is exactly what we just saw. This is a paradoxical worsening of pre-existing OI after you start ART. So why is that? So basically, when you had no CD4, your immune system was down in the dumps, you had nothing to react to what was going on. Now your CD4 is up, and then all of a sudden it's like, oh wait, I'm supposed to do something about this. So it's more of an exacerbated inflammatory response as opposed to an active infection. So your CD4 pre-ART is usually 50 or less, and your post-CD4, your post-ART CD4 usually goes up to above 100. So it's that the degree of immune reconstitution in that short period of time is what seems to trigger this. And so exacerbated inflammatory response. So this is a handy table, which most of you probably can't see from back there, but this is how you kind of try and distinguish these two things, because it can be very, very hard, especially if it's early on the course of starting the ART. You don't know, okay, did the initial infection completely resolve or what? So how do you tell these apart? So first of all, immune reconstitution is restoration of a pathogen-specific immune response. When you have immune deficiencies, basically you don't have a protective immune response. The viral load in immune reconstitution should have gone down from baseline, whereas if it's an immune deficiency state with an infection, it should be high. And the opposite for the CD4, it should be increased after ART, whereas it will still be low in immune deficient states. Inflammation, it's exacerbated immune reconstitution, whereas it's blunted when you're just immune deficient. And testing, so sometimes the tissue will help you a lot, because if you get a biopsy, you will see scant pathogens if it's immune reconstitution, whereas you'll see a lot if it's a true infection. And again, we talked about immune response already. And the treatment, so for immune reconstitution, a lot of these guys resolve spontaneously after that initial exacerbation. Whereas if it's an actual infection, you're going to need antimicrobial therapy. So this, to figure this out, it's a combination of clinical symptoms, timing, CD4 and viral load responses, and tissue if you can get it and if it's feasible, okay? So as far as the ART, it's essential that you continue that, okay? We don't stop the ART, we keep going with it, okay? And again, we talked about this already, biopsy when possible, and you can consider adding steroids because it's inflammation, right? But when do you add those steroids? In specific situations. So if you have cryptococcal or tuberculous meningitis, you can add steroids because obviously if it's up here and you have all this inflammation and you have cranium, there's nowhere to go. So you want to decrease that inflammation. So in those cases, if you have CMV uveitis, you can consider that because that can be sight-threatening if it's just inflammation. In some MAC cases, you can consider adding that too, just to help with symptom relief, because especially if it's in the gut, they can have really severe abdominal pain, and that might be the only thing to give them symptom relief, okay? And the other important point here is timing of ART. And that's why sometimes when you have those sick patients in the hospital and they had pneumocystis and you're all asking us, why aren't you starting the meds like right away? Like, what are you waiting for? So our concern is several things, but one of them is the timing of ART in these inflammatory conditions and the risk of iris, okay? So there's two situations where you should definitely delay ART starting. And these two situations are cryptomeningitis, which you should delay by at least, this is a minimum suggested, 2 weeks. I sometimes like to wait till they finish the 8-week consolidation. It's just that when this inflammation happens here, it's very difficult to control. But at least 2 weeks you should wait to minimize the risk of iris, because your objective is to try and clear those pathogens as well as you can so that you don't have too much to react to when your immune system reconstitutes. The other one's active TB, and this also there's two stratifications. So, and this kind of makes sense. So if your CD4 is really low, below 50, your mortality is going to be super high, right? You have active TB and you have HIV, which is advanced. So in that case, you should just start the ART. But even then, the immediately starting is 2 weeks, okay? You want to start your TB therapy. You want to get that going. And then in 2 weeks, you can start your antiretrovirals, okay? That's if your CD4 is less than 50. If it's more than 50, actually, then in that case, you might want to wait a little bit more, and you can, if it's severe disease and it's more than 50, then you can wait 2 to 4 weeks. If it's mild to moderate disease and you're well above the 50s, like 300, you can afford to wait to start antiretrovirals up to even 12 weeks. And that's okay. Sometimes that's helpful because they're already on so many medications. For TB, you need 4 medications to start with. And then if you're going to add the antiretroviral and then the interactions and then the compliance. So that might be even helpful in the beginning. But these are the two situations where you must absolutely delay ART. For other things, so pneumocystis, a good rule of thumb for me is I usually wait 2 weeks is my general waiting time. But if you ask me, do you absolutely have to wait the 2 weeks if you had pneumocystis and you were in the unit? You don't absolutely have to, but, I've seen iris with pneumocystis and it's awful. So, I think the 2 weeks in the grand scheme of things is reasonable. So it's all about a judgment call, but those are the two situations where you absolutely must wait, okay? And this is the last slide. This is just a summary of the CD4 counts correlating with when you get what. So you can see with tuberculous meningitis, any CD4 count, you're at risk. Whereas the other ones, it just depends. So Toxo, PML, and Crypto, it's like 200 or less. CMV, it's like lower, 150 or less. It's just an easy way to remember when what happens. And I think that's all I got for you guys. And I apologize for the technical difficulties. Any questions? Yes.
So how often do you see relapse of these conditions, especially in the longer treatment?
Yeah, we tend to see this mostly in the non-compliant. It just depends on each disease. There's no great studies as far as the exact percent risk or relapse. We kind of have an idea of how bad mortality is, pre-ART. But yeah, it's all about each person and compliance. Yes?
Say like patient like this with iris comes in the ward. The
how do we make sure like we don't cover them for community-acquired?
Right, so in the beginning, most likely you're going to be doing some empiric things, trying to figure things out. And so it will depend on, of course, because your x-ray is going to look bad because you're going to have inflammation. So it's okay to start out like that, but as you go along, you're going to see, you know, try and get the tissue, try and see what the increase in the CD4 was, if the viral load came down abruptly, and that will help you decide. And, you know, we're usually... you know, we try to navigate that along with you guys, but it's not wrong to start what you think might be going on. Like, they could have a pneumonia, you just don't know. So,
are there any reliable risk factors for iris prophylaxis when we get someone who just had NOI and
right, so in terms of what to look for, it would be the increase or decrease in CD4 and viral load. That would be, and you might not have that information right away.
Right.
So that would be the main thing. And in the patient history, of course, that, yeah, I'm taking my medicine every day. You don't know, you know, yeah. And again, it's really the feel for the patient. If they got better, they got all better, and now this is coming back temporarily associated with initiation of heart, that's a big clue for you. Yeah. Mm-hmm. All right.